session this morning is on aortic and visceral artery disease. I'd like to invite Dr. Lou Martin back to the podium, and he's going to talk to us about quality improvement for the endovascular management of renal artery stenosis. Dr. Martin.
Thank you. It's nice to see some other people got out of bed early this morning. I know you're probably all sore and tired too. I have no conflict of interest to declare on this topic. And what I'm going to say is primarily what went into the production of this document with the Standards of Practice Committee from the Society of Interventional Radiology. Produced a document that I think it's been produced and reproduced many times over the last 25 years. And this particular document was first produced, published in about 2005 and then revised and republished in 2010. And I'd like to discuss the document with you in a little bit of detail. There really is no conflict in the conclusions of this document with that produced by the American Heart and or most other major organizations. The methodology that went behind this document was first, for those of you that don't spend time doing this, and you may wonder how we arrive at this, and first we do an in-depth literature research, and then qualitatively weight the articles that we've assembled as in an evidence table. And when the document is written such that it contains evidence-based data as much as we can with respect to the content, rates, and thresholds, and when the evidence is weak or contradictory, consensus for the parameter that's in question is reached by using a modified Delphi consensus method, which means that we all sit around and keep voting on it, and you're sort of put in a locked room, and you have to keep voting and voting until a consensus is reached. The draft document is then critically reviewed by the revisions subcommittee members of the Standards of Practice Committee, and the finalized draft from the committee is sent to the SIR membership then for further input and criticism, and these comments are then discussed by the subcommittee again and appropriate revisions made and finished, and the finished document published or assembled. But before its publication, the document has to be endorsed by the Executive Council of the Society of Interventional Radiology, and then it also goes through and it's collaboratively published by the American College of Radiology, so it has to also be approved by them. So it's nothing that goes into this document is taken very casually. Everything you can see is discussed and fought over. There were certain working hypotheses, I guess, with this document, and there are not a tremendous number of them, but the first one is that cure is not a reasonable goal in adults with atherosclerotic renal artery disease. Just a very few patients ever cured of their hypertension, and even when you see that 3 to 5% of patients have been cured in a series, you really have to wonder how long that cure is going to persist, and whether it's just completely, it's very, very unusual anyway. The hemodynamic significance of a stenosis must be established prior to treatment, and this usually means, and this is difficult. We feel that most of us feel, angiographers, that we can take a look at a stenosis and say this is 75% stenosis, this is 80%, this is 50%, and you're fairly accurate at it. You've been doing this, it seems like, all your life, and you're fairly confident that, but you really can't get right-angle views of the renal artery because of its position in the body. And so it's a little bit harder in the renal artery than it is otherwise. And so if a linear stenosis, that means that the narrowing of the blood vessel is 75%, then that's a horrendous stenosis. It's about 90% of the circumferential area. And there's really no need to put a pressure wire or try to make a pressure determination to see if there's a pressure gradient across the stenosis. But the stenoses in question really are down about 50% and 60%. And we think that a 50% linear stenosis, so the cardiologists have told us, of course, is a 75% stenosis of the cross-sectional area, and which is significant clinically if you get there. So we feel that those lesions that are down in that category really need to be evaluated carefully and have to be substantiated. And we could not come to consensus on how to do it or what the standard should be, and we argued about this. And then I guess we couldn't come to Adelphi. They locked us in the room, and we still refused to budge. And so we determined that we thought that the interventionalist that's performing the procedure should make his own standards there, that you should go ahead and decide for yourself what you consider a hemodynamically significant stenosis is on a pressure measurement, measuring the pressure gradient across that stenosis. And you should stick to it. And there are a lot of articles out there that I think are fabulous and tell you how to do it and how to do it the best way. And I personally prefer to use a 014 pressure wire for my measurements. It has very little effect on the stenosis. It's very difficult to measure anything without altering it. And so if you're putting a catheter across the stenosis and trying to measure it, if you're not measuring simultaneously, if you're pulling the catheter back and measuring a pressure gradient across it, there are all kinds of errors. So you really should try to, I think, strive to measure the pressures concurrently so that the pressures are synchronized between the intrarenal pressure and the pressure in the aorta, and figure out how you can do it and what you're happy with. And as I said, you don't really have to do it on everybody. You just have to do it on those patients that you know are in question. And then that the clinical indication for treatment is failure of optimal medical management. And so that you really shouldn't do a angiogram. And the reason for that is because of the first statement, that cure is not a reasonable goal. And so if you're not going to cure somebody, there's really no reason to treat them unless they failed optimal medical management. Now, I certainly can't manage anybody medically in an optimal manner, so I have to rely on nephrologists and hypertensionologists and internists and other people to do that for me, and assume that they're doing it. And so we'll go over some of the standards, how these are applied. And these are quotations from the document, and this is it's the majority of patients with hemodynamically significant renal artery stenosis associated with hypertension and reduced renal function can be managed medically without risk of increased mortality or progression to end-stage renal disease. And we think that's a very important statement, and that's sort of one of the basic elements of the document. And that blood pressure control, renal mass, and renal function must be followed very closely if you choose to treat somebody medically. And so the person that's doing that, they can't just treat their blood pressure and not look at the kidneys. They've got to follow the patient with an ultrasound, at least, and well, at most probably an ultrasound is a very good way to follow them, and follow the renal size. And if the renal size doesn't change, and you're taking a look at the blood vessels and they stay about the same, and the function, you're following a creatinine and it stays, it doesn't have a sharp drop or something that can't be explained just by the aging of the patient, then those are reasons for you to go on and into a further evaluation. I guess I'm going to go over these clinical signs sort of rapidly. You've got them in your handout, but some of them are important. And these are clinical signs of renal hypertension, which should prompt a non-invasive screening. And the non-invasive screening really could be an ultrasound, which we think the medical people, that we should have anyway, or it can be an MRI or a CTA. And the history or recurrent onset of significant hypertension after the age of 55 years, an abdominal bruit, especially if it continues into diastole and is lateralized, accelerated or resistant hypertension, and usually that means that hypertension that can't be controlled on 3 drugs, one of which is a diuretic, a recurrent flash pulmonary edema, renal failure of uncertain cause, especially with normal urinary sediment and less than 1 gram of protein per day in the urinary output, coexisting diffuse atherosclerotic vascular disease, especially in heavy smokers. And we know that renal artery stenosis is a marker for cerebral vascular disease and coronary disease, and likewise they're markers for renal vascular disease too. So you have to be very wary if you're treating a patient for coronary disease or cerebral vascular disease, that their kidneys may not be functioning quite as well as you'd like. And acute renal failure precipitated by antihypertensive therapy, especially with angiotensin converting enzyme inhibitors or angiotensin blockers, receptor blockers. Malignant hypertension defined as hypertension with an end organ damage, including left ventricular hypertrophy, congestive heart failure, visual or neurological disturbance, or advanced retinopathy. Hypertension with unilateral small kidney, and hypertension associated with medication intolerance. And I have to say that we've done close to 1,000 renal artery angioplasties at Emory over the past 30 years. And I can't think of 2 or 3 patients where they couldn't tolerate the medication. Some may be resistant to taking it because they just don't realize the significance of it. And unstable angina in a setting of suspected renal artery stenosis. Indications then for catheter-directed. Who should get catheter-directed diagnostic angiography? So we've already passed this. We're very suspicious that they've got a significant stenosis. So the non-invasive vascular imaging, including the ultrasound, suggests that a significant renal artery stenosis is present, meaning that it's greater than 50%. Non-invasive imaging is not likely to have an adequate sensitivity or specificity. And so when you get down to that 50% thing, or 60% or 40%, it's really tough to tell on a MRI whether it's actually a stenosis or if you look like they've got FMD, and you really can't tell looking at an FMD whether it's significant or not hemodynamically. Onset of hypertension occurs in a patient under the age of 30 or older than 30 years but has FMD suspected on the non-invasive studies. There are appropriate indications for screening and a very high clinical suspicion of renal artery stenosis, in which case non-invasive screening can be bypassed with appropriate indications. And then in patients with strong clinical signs of renal artery stenosis, while evaluating another organ system, i.e. a cerebral or coronary or peripheral, and this is what I'm saying that it is, and we're sort of endorsing drive-by angiography. And I think really that if the patient has the clinical signs of renovascular hypertension, and you're doing a coronary on the patient, or you're doing a carotid, or you're studying the aorta for a different reason, or the tibial artery or something like that, then you really ought to go up there and take another 5 cc's of contrast and squirt it in the renals and try to figure out whether they have a renal artery stenosis. It potentially can do the patient. It doesn't mean that they should be treated. Then it's the operator's responsibility to make sure that they are receiving optimal medical therapy and that they've failed it. And if they haven't been treating it, they've got to be put on it, and then they have to fail it, and then you should go on to treating. But I guess in some instances you might even be able to tell that they need treatment at that time too. So indications for renal artery stenting or angioplasty in the presence of a hemodynamically significant stenosis, they have to have failed optimal medical therapy. I know I keep pounding at this, but this is very important. So it's uncontrolled hypertension on 3 medications, loss of renal function or mass on antihypertensive treatment, which means that you've really got to be following the serum creatinines, and you've got to be following the size of the kidneys with an ultrasound examination. Hypertension with an unexplained unilateral small kidney, unexplained recurrent congestive heart failure or flash pulmonary edema, hypertension with intolerance to medication. I know that a lot of these things are redundant, and I keep harping on it. And this is sort of an algorithm of how I feel that we should be treating these patients, and this is supported in the document. And I don't expect you to see it from your seats, and I can't read it from here, although I know what it says. But at the end of each one of those little points is optimal medical therapy. And so you have to be controlled on optimal medical therapy, no matter where you're going in the graph there. So we'll take a look at a couple of them. So if a patient's got hypertension, they should be treated for it medically, and they should get baseline serum creatinine and ultrasound examinations. And if the hypertension is controlled and the renal size is symmetrical and pretty normal for their age, and the Doppler ultrasound doesn't show that they've got a stenosis, then they ought to just continue on medical therapy. It doesn't mean you can forget them. They should be periodically checked to make sure that they haven't gone into a disease, renal artery stenosis state. If the hypertension is controlled, but there's asymmetric renal size or abnormal renal function or an abnormal Doppler ultrasound examination, doesn't mean that they need to go on and be treated. It means that you've got to figure out whether they need more studies. And so if you should continue on optimal medical therapy, especially if they're over 40 under those circumstances. If it's a child or an adult that's under 40, then you really have to be suspicious that they might have renal artery, might have FMD. And FMD can be cured. It's not like atherosclerosis. And so the cure rate in FMD it really varies depending on what articles that you read, but it's somewhere between 25 and 60%, somewhere in that range. And the benefit rate is probably up close to 75 to 80%. So chances are the patients are really going to have a tremendous benefit from intervention for FMD. And so if a child or an adult that you really suspect FMD on, you've got to continue. So this is abnormal surveillance this is the patient that has abnormal surveillance in an adult over 40. And they need to get an MRI and a CTA or a MRA. And if they're seen to have renal artery stenosis, then they should go on to angiography. And if they have a significant stenosis, then they need to be treated, either with angioplasty or stenting, depending on the disease process and what's at that time. And then they go into the optimal medical therapy thing again. If they don't have a renal artery stenosis on those, then they just go on to the optimal medical therapy again. So the abnormal surveillance in the child or the adult under 40, I've already just said this. If they don't have renal artery stenosis, of course, you just continue on medical therapy. And if they do, then they need to be treated. And so basically, it's not very hard. That algorithm is pretty easy to follow. And there are a lot of studies out there that say that renal artery angioplasty and stenting is not beneficial. And then there have been 4 trials now, prospectively randomized controlled trials on renal artery angioplasty, and there are problems with all the trials, as I tried to say yesterday, and I didn't say it very eloquently, but I tried to say it. And but those trials, none of the trials showed any benefit from renal artery angioplasty or stenting, a significant benefit. But they really were looking at the wrong thing, mainly. What you really have to do, these patients have already failed. There's no other choice. So you either go on with failure and progress on to worse chronic renal artery disease or into dialysis, or you treat. And so it's not really, you're starting at that point. That's not the end point, that's the start point. You're not taking a look at the failures. And the CORAL trial, I know, has completed, I think, enrollment, and some of the early data will probably start coming out in the next 6 months. And the CORAL trial is randomizing optimal medical treatment. Everybody in the trial gets optimal medical treatment. And the patients, though, are not left at that. They've got they have documented renal artery stenosis and they're on optimal medical treatment, and they're going to treat some and not treat others, and they're going to see how that affects longevity and stroke and MI and other endpoints and renal failure. And so those will be the endpoints on that. And so we'll see whether we should be going into a different algorithm, expanding the algorithm. But for right now, if they're being treated by optimal medical therapy, then that is our endpoint. You can't do better. There's no sense in starting when you've already reached your endpoint. Thank you very much.